Thank you very much, Joris. Yes, it's a great pleasure to introduce John Zupancic, who I've met a while ago, pre-lockdown, at a conference, and we've discovered a lot of similarities in our thinking and in our work. And it's a great pleasure to welcome you to the NDPH, the Richard Doll Lecture today. John is an associate professor of pediatrics, and he's also the associate chief of neonatology at Beth Israel Hospital, Deaconess Medical Center in Boston, Harvard University, and the director of Exploring Pathways to Optimizing Child Health program, which oversees where you oversee the neonatology clinical research, which is also your obligation at your institution. John has got many foci in medicine, but most of all, he's also trying to focus on how we can optimize looking into the health economics in trials. He's a keen clinical trialist and a very well-published researcher. He's going to give us an overview today on the Neonatal Canon project, and I'll leave it to John to continue. And please don't be shy, ask many questions. Also to the audience out there, thanks for joining. The floor is yours, John. Thank you
very much. Thanks very much, Charles. Thank you to Professor Hemmeler and Rohr for the invitation. I will start by just remarking that I know that coming to speak about clinical trials, and in particular the aggregation of clinical trials into data sets to Oxford Population Health, is a bit of coals to Newcastle, as my wife would say. And so I'm hoping that this discussion can really be one in which I maybe provoke you a little bit and learn from you, and have a really interactive sort of session. I'll also say that whenever where am I here? Okay. So the second thing I'll say is that my task in these discussions is really to reflect the work of a number of people. These are the individuals whose work I'll be presenting today. I'm essentially a town crier, and we'll be speaking about specific contributions of some of these students and early career faculty people, and then also about a project that all of them were involved in aggregating trials into data set. I've given this talk or spoken about this project a couple of times in the third week of May, and I've never actually hit Clinical Trials Day, but so I wish you a belated Clinical Trials Day, which, as you know, celebrates what is celebrated as the first trial of James Lind, who was dealing with the issue of scurvy, allocated individuals to a number of treatments through methods that we don't really know in retrospect. This is applicable in some ways to what we're going to be discussing today. I don't know if this would have ended up in our data set. We don't tend to use elixir of vitriol in babies, but I think some aspects of this, the fact that people had known for a long time about a therapy that might work, that had never been subjected to a test, and then after having the result of a trial, 42 years went by before a guideline was applied. So this process of discovery through to eventual dissemination of results was something that really hasn't changed in the past 250 years or so. Just to give some historical perspective about how we got to this data set, Archie Cochrane, who had been tasked with thinking about the delivery of health services here in the UK, and wrote a book that you probably know about, the effectiveness and efficiency, which he called Random Reflections. They were not random at all, on health services. Basically was thinking about this principle that health resources were limited, and so we have to use the most effective evidence to provide care. And I came into what I'm talking about today through economic evaluation, really driven by this idea that efficacy is economics. He emphasized the idea that RCTs, that low bias studies, would be the best way to understand what is efficacious. And then, of course, after a few other individuals developed this over time, Professor Chalmers made some very important contributions. First, in creating the first data set that was kind of the prototype for what I'm a fully developed prototype for what I'm going to be talking about in a very small niche, the Oxford Database of Perinatal Trials, and then of course developed the National Perinatal Epidemiology Unit. And he talked in an interview about this idea that there was this rather obvious, in one interview I heard he called it the bloody obvious deficiency within which not only here in the UK but in most countries, that we just don't have access to reliable digested summary synthesis of the relevant evidence, and that it's not up to date. So could we create a database that is electronic and that is summarized? And that, of course, led to Cochrane UK and then subsequently to the Cochrane collaboration. So I grew up in McMaster and the company of these eminent professors in the late 80s through to the early 90s. And at the time, Professor Sackett had just developed the idea of critical appraisal. He had published what were at those time called the Reader's Guides to the medical literature in the Canadian Medical Association Journal, really looking at how to assess bias in studies and then how to think about applying that to your patients. And then Gord Guyatt, of course, in 1991 coined this term of evidence-based medicine that basically extended the idea of critical appraisal into something that included not only critical appraisal, but evidence-based physical examination and patient values and preferences, and then eventually got this out into the development of guidelines through the GRADE approach and evidence to practice. So, you know, in that short period from 1972 to 1991 or in the mid 90s, we had gone from a period of time where we were kind of, practicing what was called evidence-based medicine, all the way through to the point where we were starting to think about how to get the best evidence in front of clinicians to be used. This had worked its way into neonatology. The person on the left here is Bill Silverman, who famously wrote about the kind of therapeutic byways and misapplications of poor evidence that resulted around retinopathy of prematurity, or specifically around oxygen use in preterm infants that caused very bad retinopathy of prematurity. And he cautioned us in neonatology to really think from the earliest point of a technology to use more low bias approaches, and said that, yeah, trials are hard, but hardship is not sufficient reason to suspend the rules of evidence. One of my clinical mentors, Jack Sinclair here, took that after doing a sabbatical here with Ian Chalmers, took that back and started the Cochrane Newborn, which was the third review group in the Cochrane collaboration. And since then, as he had actually started with this book, Effective Care of the Newborn Infant, which built on what Ian Chalmers had done and Murray Enkin, but then translated that into Cochrane Newborn Review Group. So what do we do? What are we doing well in neonatology? Well, what I've described is really a process of learning from what Professors Cochrane and Chalmers had advised us to try to synthesize evidence, and what Professors Sackett and Guyatt had taught us, which is to really appraise that evidence and think how it might be helpful to patients. So in neonatology, the Society for Clinical Trials awarded its inaugural trial of the year to a neonatology trial, the Caffeine for Apnea Prematurity study. And that was really a groundbreaking trial in part because it challenged a really fundamental lack of equipoise around a drug that had been used for decades with kind of minimal evidence, and for which there were some signals that it might be harmful. Somehow randomized between placebo and intervention at a time when that seemed impossible, and then achieved nearly 100% follow-up. So that trial and another one in neonatology on fetal surgery for a myelomeningocele have both been sort of recognized in the 16 years of this study, as has recovery, of course, famously a few years ago. So I think we're good at doing trials. There are good trials that will show up in this data set, regardless of how critical I'm going to be about our overall endeavor in a minute. We're also, have made some real accomplishments in neonatology in evidence synthesis. As I said, Cochrane Neonatal was a third review group in Cochrane. We have over 400 reviews now, 52 authors, 1,000 trials in those reviews. So we're really, concentrating this, and clinicians use those reviews really to help guide practice, except in the most controversial areas. But what don't we know? What haven't we accomplished? And I think I'm going to posit today that the work essentially isn't finished. It isn't done. That while we've thought about how to do a good clinical trial and to recognize that, and we've thought about how to synthesize the trials towards treatment choices, we've kind of ignored the overarching view of our work. And somebody once said it's not what in a collection, it's not what you include in the collection, it's what you leave out. And I think that speaks to some problems that we also might not be solving through that perspective, specifically efficiency in research conduct that might be optimal, so that we're not being appropriate stewards of societal resources and also patient participation. There might be gaps in the topical coverage in a particular subspecialty. There might be suboptimal comparisons and suboptimal questions being asked. And then what I've found is that there might be hiding of good trials in the noise of hundreds or thousands of trials that clinicians are expected to understand. So in order to answer the sorts of questions on that slide, we had started thinking about what the impact was of trials and how to kind of measure that. And we undertook a very practical descriptive study that basically looked at the impact of the last study added to the Cochrane reviews, to those 300 Cochrane reviews in neonatology. This is the work of Susanna Hay on my faculty. So obviously in traditional pairwise meta-analysis, each line of this forest plot is an independent contributor that is weighted by the inverse variance. And that contributes to this typical estimate down here that, as I said, is what clinicians in neonatology tend to use if they're paying any attention to the literature at all. They'll quote that. But we really don't know, where on this list of trials we had an answer, or whether we do in the end. So this doesn't speak to impact of a particular trial, and it doesn't speak to whether we've done too many or too few studies. So we used cumulative meta-analysis, which basically moves back in time on that forest chart, a forest plot, and starts with creating a forest plot with the first chronologically available trial, generates a typical estimate, then adds in a second trial, generates a new typical estimate, a third trial, new typical estimate, and so on. And if we thought, well, if these trials are still important at some point, what does the last trial added across all of the studies in Cochrane do to the typical estimate compared to the second last study added across Cochrane? Now, this obviously is limited in a little bit because it really just prioritizes this last published study, which may or may not be the last generated study, but it gives us some idea across hundreds of domains as to how that has changed, at least the quantitative information that we use. So Dr. Hay looked at the time, there were 339 Cochrane reviews, and she looked both at the stated primary outcome of the last study and at mortality, thinking that those were the two issues that probably would drive clinicians to accept or reject a particular result. And what she found in doing cumulative meta-analyses, basically redoing the forest plots by using cumulative meta-analysis across all those studies, was first of all that we had a median number of studies in the 3 to 4 range, with about 30% of the reviews having more than six 6 trials contributing to them. And a very small number having the number that I just showed on the probiotic forest plot there. And we basically took as I said, a simple kind of descriptive approach, and we asked, well, first of all, what about precision? What is the impact of that last study added on the precision of the estimate that we have? How much is the confidence interval changed? And what we found was that the confidence interval either expanded in a small minority of cases, so we actually lost precision on the last study, did not change, or changed by a relatively small amount in the 10 to 20% range that might ask one whether cause one to ask whether that is significant. We also obviously asked about the risk ratio itself, and there we found that on studies that had reported a risk ratio, it had changed by less than 10% in about 50% or a little more than a third rather of studies that were performed, and in both directions. And then finally we asked, well, as we've changed the precision and as we've changed the risk ratio, has there been any impact on significance? And found that in the large majority of cases, statistical significance had not changed. And these results I'm giving you applied to studies that use weighted mean difference. They applied to studies that looked at mortality. They applied to reviews that looked at the last study added. So very, very consistent. So what we learned from that was that more than half of the last studies added failed to shrink the confidence interval by very much, at least, that more than half didn't move the relative risk by more than about 10%, that very few of them changed statistical significance. And then in work that I didn't show you, the ability to shrink the confidence interval is not surprisingly negatively correlated with the number of studies that were already there in review, and positively correlated with the last study that was introduced. So that's I guess reassuring when we think about how we think about sample size. So I'm presenting, as I said at the top, I'm going to try to provoke you here with provoke your ire or enthusiasm. So should we, and these were originally questions. I've changed them to resolutions so that we can think more about them, and we should give more formal consideration to whether and how to conduct an RCT when literature already includes others. So not just whether there's somebody on a review panel who thinks this is a cool idea, but in the context, formally, quantitatively, of everything that's come before, is this going to be a useful study to undertake? Okay, well, we then started asking ourselves, well, if that last study added is across hundreds of reviews, not really changing the landscape very much, what is the bigger picture of what we're doing in neonatology? Is that the problem? Is the quality of our studies suboptimal? Are we asking the wrong questions? Are we doing the studies incorrectly in the wrong domain? And so we undertook this project that's been going on now for a number of years, called the Neonatology Canon Project, which was really targeted at putting all neonatology RCT knowledge in a curated, validated data set. This is the Library of Alexandria, which in my more grandiose moments, I think, well, this is kind of what we're doing. And the idea here was not just to optimize the sensitivity of the data set, which has already been well optimized in Cochrane reviews, and obviously in Medline. Everything that we could want to know is included probably in those, with a little bit of a rounding error on the gray literature nowadays, with at least post-trial registration, but also the specificity. So we wanted to be able to go to this, look at the universe of trials that had been published, and make some comments about how we were doing in neonatology with the studies that maybe had not found their way into reviews. And that gets us at this idea of research efficiency. So the target outcome was to create searchable citations, abstracts, and full text. And in an initial kind of parsimonious extraction prior to the availability of the current levels of full text review, which I'll talk about at the end of the talk, we asked, what is the quality of RCTs overall according to a couple of metrics. I'll show you what have we studied, what are the content holes, what are we comparing, how are we making comparisons, and what is the burden of participation for patients. We relied initially on Central, Cochrane Central, which has, as I said, is highly sensitive. It uses a number of different approaches to pull information from PubMed, Embase, CNL, some registration sites like clinical trials and ICTRP, any studies that have been included in reviews, specialized registers from either for example, the neonatology review group or from the geographic review groups, and networks like Child Health, anything that they've collected through their own means, and then from hand searching. And we looked at basically all trials. The target was all trials from the time at which surfactant was introduced, which was really a seminal moment in neonatology forward. And although there's information from before that, it may not provide us with applicable lessons to now. I'm going to be presenting on a 15-year period with most of the data here. We have up to 2023, but are still kind of cleaning those data. We used a very broad search of Cochrane, and that and basically took everything we got from Central and applied these inclusion criteria to it. I'll just tell you that Central has a lot of information on babies that as the outcome of obstetric trials. It has a lot of information on babies who are included in studies of older infants, and it really is very difficult to use keyword searching to narrow it down to what neonatologists do in a really reliable way. So we use these inclusion criteria. Interventions started at less than 31 days of age, and at a month or less, or in babies who had never been discharged home after birth. We actually included a couple of things like simulation. If the simulation was targeted, if the mannequin in front of you or the program was targeted at the same thing as a baby. We did not, however, include animal studies that were in that range. Obviously had to be randomized with formal statement of how that randomization occurred. Now, although the first pass was English only, now we've been able to use any language with modern translation techniques, which was very easy, and the full report had to be available. We excluded things, interventions that had been started prenatally that didn't have an intervention given postnatally. We included the ones that actually provided something to the baby and allocated baby along with mother postnatally. The one exception was fetal surgery, because we thought that had there was a fundamental difference there between administering steroids to mom versus actually touching the fetus and baby. So we included that. We included cord management. And then we also excluded follow-up studies. So the initial search yielded about 57,000 abstracts for that period of time, and we manually screened those to derive 4,000 or so, and then after pulling the PDFs, have about 3,800 so far in this period that I'm going to be talking about today. We then validated this. Basically using our whole process as a diagnostic test. We looked at the proportion of trials that met the inclusion criteria that were included in our study, and obviously it's difficult to have a gold standard for that, so we used studies that had made their way into a forest plot in Cochrane, thinking that those were the studies that we are mostly going to be using to manage practice, and we just chose randomly across Cochrane neonatal reviews and determined how many of those studies showed up. In the initial pass through, we had a sensitivity about 94%, and this is, by the way, for meeting all of our inclusion criteria, right? And we've since kind of added Cochrane to all the Cochrane trials to that, and we'll will iterate on this sensitivity testing. The specificity is the proportion of RCT trials that didn't meet the inclusion criteria that are not included in our data set. And there we basically pulled those from Medline, and not surprisingly had a 100% specificity with a very low false positive rate. Here's the trial productivity by year over this period of time that I said we'd be talking about in a couple of years extended beyond that. And what we see is that in the early 2000s, we were producing about 150 studies per year. And that has, after being stable for a few years, it's really taken off. I think I'm not sure exactly why this is happening, whether it's in the digital age that there are a lot more journals available. Some of the spikes we know, as you know, if you're on a journal, you know that there was a spike in submissions in 2020 and 2021 as we all had time to finally catch up probably on what we were doing. But the important thing I think from this slide is that we're generating a lot of trials per year. And as a clinician, you can imagine that you probably, if you're like me, you probably are not reading 2 trials a day and really digesting those in any significant way. So my second provocation is, are we producing too many, I'll call them trivial trials, to make the point that there are trials out there that probably we're not paying any attention to. How about the class of the intervention across these 3,000 or so trials? We see that most of the trials, the plurality of the trials are on drugs, and the others are kind of distributed evenly across devices, procedures like how to place an IV, how to intubate, those sorts of things, programs and simulations, educational programs, developmental interventions, formulas, biologicals or vaccines, and so on. So this is interesting. If you're a neonatologist or an intensivist, you'll know that most of what we do, there are actually a really fairly modest number of drugs we use, whereas every baby has devices that they're responding to or being treated with. So the number of device trials is actually, I think, very low for what it is that we do as intensivists. So my provocation on this chart is that the attention to drug trials doesn't really reflect, I think, the reality of neonatal intensive care. How about study design? Not surprisingly, parallel group trials were by far the majority, as were superiority comparisons as opposed to other sorts of comparisons. So the provocation here is that we might be underutilizing tools like factorial design or other kinds of analyses. At this time, up to 2015, I'll just say I on that chart I had superiority and inferiority equivalence trials. There were no Bayesian analyses that I could find in the data set. So I think we're not necessarily pushing forward on other means of answering questions, and that may be a deficiency of the questions we're asking. How about gestational age inclusion? Well, most of our studies, or the plurality, were about half are in the preterm population. The thing I found interesting about this chart is that there's a large group of non-specified gestational ages. So if you think that a third of studies are not reporting a gestational age, that's probably a reporting failure. And the other thing is, think about term deliveries. There are, 2.3 million deaths a year globally, 6,500 a day. Prematurity is one of the causes of those, but the other causes are hypoxic ischemic encephalopathy and congenital anomalies, and that those will generally fall into the term group. So are we under testing therapies in term infants? As an add-on, I haven't shown it in this chart, but in a sub-analyses, we broke down preterm, and the number in the moderately preterm group is also very small. So the lesson is that these are mostly the smallest babies, probably the highest potential technological impact, but not necessarily the impact that you might be getting if you addressed a high volume population with underlying risk. So we are paying are we paying inadequate attention to the potentially higher impact, high volume term population and moderately preterm? What about sample size? I've referred to that obliquely a couple of times, and this is work of one of our visiting fellows, Dr. Castellanos. So overall, over about 3,400 trials in her data set involving 800,000 participants, babies, by the way, and these are the non-cluster trials. So this pulls out the largest studies that for which it was a little unclear how many babies were actually being reached. So this is just babies who are directly enrolled. The median sample size was 76, or sorry, the median, and the mean was 245. So we have a right skewed distribution of sample size, and in fact, more than half of our studies have fewer than 100 participants. So that's across thousands of studies, and I could say that, you know, with the interventions that we are testing nowadays, that the effect sizes are not going to be accessible with studies of only 100 patients. There are, you know, occasional studies or occasional applications where that will happen. Surfactant was one that was kind of obvious. What I call the parachute studies, you know, the studies that are really going to change the needle, but those really are few and far between. So I would say that the precision of the 60% of these 3,000 trials is probably inadequate for what we're doing. So I'm going to propose that we should consider restricting resources. Just say if your study is not well powered, there are no resources available, because we can then divert those resources to other studies. How about the funding source, which is always something that's a background concern? In this case, we looked at 2,600 trials. A third of them had no comment on funding at all, which is obviously worrisome. That's been decreasing over time. Importantly, though, there was in about 70% of studies, there was a significant result in the abstract, which I found just extraordinary. Like, we are either choosing therapies extremely well, or we're subjecting our trials, our abstracts, to hype and spin, to be a bit jaded about it. And what we found also is that if you did not report a funding source, you were more likely to report a significant result in the abstract. But surprisingly, studies that overall that had been funded by industry had a lower chance, slightly, of reporting a significant result in the abstract. So that may speak to the idea that there's more oversight to those. That's a complete guess. I don't really know. There's been that these funding sources, studies that had no funding source stated, were also likely to be smaller in general. So yeah, my provocation here is that I think we may be guilty of publication bias at scale, and maybe, as some journals have done, restricting the reporting in the abstract to primary outcomes that were registered might be a way to avoid that. Now in the U.S., and I understand this is an issue here as well, the idea of the burden of participation in trials has become a bit of an issue. We looked at trials in the U.S. that 590 of them over the 15-year period of that I mentioned earlier. This is Adrian Baca, who's another one of our international students from Mexico, who's now going to residency. He did a very good job of this study, which looked at whether studies reported race and ethnicity. It's only 50% of the studies in the U.S. had reported race and ethnicity. Only 11% had reported language as an inclusion or exclusion criterion. And when he compared those studies that had reported over time, when he compared the reported race and ethnicity to U.S. natality data from the CDC, from census, he found that Black non-Hispanic individuals in the U.S. were overrepresented in studies by a factor of almost 2. compared to white non-Hispanics. You see 47% to 55%. So this is something that I'm interested in speaking to you about. We had to limit this just to the U.S., to these 100,000 in patients, but mainly because we didn't have the local knowledge of what categorization should be used, because this is obviously very different from country to country and probably even from region to region within a country. So I'm interested in hearing your thoughts about this. So in the U.S., we may be overburdening some minoritized populations with research participation. Of course, the alternate to that hypothesis is that those individuals, through other issues with our healthcare system, may actually require these interventions at a higher rate. So our comparison was to census and not to need, obviously, for intensive care admission, for example. Okay, so so that's the kind of description over these over this 15 years and these 800,000 patients. But we also wanted to ask, what were we comparing to what? So to try to get at whether we were asking the right questions, and we decided to take a graphical approach to this, essentially, similar in appearance to what we do with network analysis. So consider that we have a number of interventions, and each of them is compared to placebo. P is placebo. These are all the different interventions. Each of these lines or edges is a comparison between an intervention and another intervention. And with a placebo, you get this placebo controlled studies. We get essentially this star topology that you see here. Contrast that to what I've called comparative effectiveness trials, where essentially everything is compared to everything else. We get this sort of a highly dense graph. Or think about incremental effectiveness, which is something that traditionally has been used in oncology trials, where you start with one intervention, compare it to the next one, take the winner, compare that to the next one, take the winner, compare that to the next one over time. There's great potential for this one in platform trials, right? Because this is essentially what you're doing. You're dropping something out and then taking what's left and comparing it forward. But it can also be done in traditional trials if you're coordinating the research initiative well. So we asked, well, what's happening in neonatology, and here's an early graph here. What we see is that there are two stars, that the large majority of our studies are actually star topology. They're comparisons, at least with drugs, between placebo and something else, and between standard care and something else. That is something that we doesn't answer a lot of our questions. We ask, which is the best surfactant, which is the best setting on a ventilator, and if everything is a star topology, all we know is that, yeah, this works. So we're really not moving forward beyond, should I give penicillin for streptococcal pharyngitis versus admitting you for 10 days of IV antibiotics. We're not comparing things that might have important differences in intervention. The other thing on this graph to notice is that many of these edges, many of the lines, each of which represents a trial comparison, many of them are very thin. The lines are weighted according to the number of replications or duplications of that comparison. And what we see is that with only a few exceptions, analgesic being one of them, for example, with only a few exceptions, most of our studies are actually single study comparisons. So as we think about that balance between replication and duplication, which is a negative, we're probably not getting that balance right, I think. That same star topology was seen in device classes, in procedure classes. It was not as evident in nutritional classes, which, as you can see pretty plainly on here, look more like that comparative effectiveness approach that I mentioned early on. We're trying to think right now about how to quantify these comparisons, but I think they're reasonably obvious, at least in the first graphs, but the nuances are only going to come out as we think about using network metrics to quantify. So the problem here, I think, is that we should prioritize head-to-head comparisons and judicious replication. The other issue is that if we take a step back from what I just showed you and show the entire universe of trials, this is over a shorter period of time. It was done over about 5 years. Each of the colors represents one of those classes that I showed you earlier on: drug, nutrition, device, and so on. And what we see is that the weak connections between groups between domains of trial interventions are actually relatively few and far between. So what we tend to do is to have intervention-focused studies as opposed to disease condition-focused studies in neonatology. And it may be that we need to shift so that we're not only comparing surfactant A to surfactant B, but surfactant to a particular mode of ventilation, or to postnatal corticosteroids for chronic lung disease of prematurity, to one type of ventilation, to nutrition, to different means of feeding, like post pyloric feeding. So that last provocation is essentially that comparisons must emphasize condition-specific approaches that extend beyond those classes of interventions, ideally, and that are disease-focused rather than intervention-focused. So I've tried to leave enough time that we can have a discussion about these provocations, and I would love to hear what your thoughts are on them. I'll say that somebody called me a trial socialist the other day, because I do think that the underlying theme utilized in that process might be better focused if on a smaller number of high impact trials that meet some of these. So my call, or my proposition behind these provocations, is that maybe we should have more central coordination. And I think that the places to do that are at the funding stage and at the publication stage. So I don't know why we are able to publish trials that are not specifically designated as Vanguard or pilot trials that have only 50 patients, and yet they're being published now at a rate of 400 or 500 per year. So looking forward to your comments.